I guess you can all see my screen, huh?
Yes, we can hear you.
Okay, thank you very much, Wouter, and thank you very much for your very kind invitation. Thank you also, Nicole, for inviting me to this MicroTAS 2020 conference. It's a great honor also to be invited at this conference. It would have been great, of course, to meet face to face, but this is the way it is in 2020 with this kind of big events. And what Wouter forgot to mention in his introduction was that I also became a virologist this year. And I think many of us have become virologists and moved from our, let's say, our comfort zone in research to virology and to studying this new pandemic virus. And I think that's already a message I would like to convey to all of you, that I think COVID-19 is really, it's the success of science, and it's just unbelievable how much research has been done over the last 9 months, how much we have known so far, based on fantastic research by many people who were not necessarily working in virology like I was, but by many people who moved to this field and who worked extremely hard on this topic. So I think it's fair to say that we should be very proud as scientists, and it's a victory of science. Not so much of clinical research, that's a different story. I think we failed a little bit in clinical research, but I will come back to this. So this is why I chose as a title, Changing Direction of a Perfect Storm. It was a perfect storm announced in February 2020, although many of us, many countries did not see it coming. And that's another interesting debate maybe for later. Why did we not see this coming, this wonderful perfect storm, if I may say? But the storm has also changed directions. And this is what I would like to discuss with you, what kind of directions have changed. So this is the agenda of today. I will talk quite a bit about viral dynamics. I know that many of you are working on developing new technologies, and we've been struggling for decades to explain people what a PCR actually is. And within months, everybody knows now. I may be exaggerating a bit, but most people would now understand what PCR is. So that is just amazing in terms of diagnostics, the impact it had on the role of diagnostics. So I'll talk a bit about that. A couple of slides about duration of quarantine. I'll talk about the role of children, because there is the changing directions all the time, and it's very confusing. Actually, what is now the role of children in the spread of the pandemic? And then something I think is extremely interesting, what is the role of saliva, and how can we use saliva to control the pandemic? And I want to start with a rather complicated slide that was published in one of the landmark papers in Nature in May of this year, where they first explained the different hypothetical scenarios. It's a complicated slide. I don't have too much time to explain it, but basically they were trying to understand, if you look at different scenarios, how infectious is the virus? And it was looking at the primary case at the top of the slide, with an infection, a duration of symptoms, an incubation period and duration of symptoms, and then you have contacts with secondary cases who could get infected, and then you have different scenarios whereby the serial interval, and the serial interval is actually the duration of time between the onset of symptoms in the index case and the secondary case. So whether it's similar to the incubation time, whether it's longer than the incubation time, or whether it's shorter. And I was just trying to understand what happens with this virus and how infectious is it? When can you become infectious? When can you infect other people? And when do you have secondary cases in relation to symptoms? And so scenario 2, for instance, is what you see in SARS 2003, where the serial interval is much longer than incubation, so you are around here, and that makes it, to cut a long story short, easy to control the pandemic. A worse situation is, of course, scenario 3, where you have a short serial interval, and where you have the situation where the infection already occurs before the symptom onset. And this paper in May 2020, this paper published in Nature this year from a Chinese group, actually, and that's just to summarize, showed something that really made us very worried. And so this was the summary of the temporal dynamics that was discussed in the paper. They made statistical errors, not major errors, and had to this month sent an update or published an update with an update of the figures, but the message remained the same. But I just want to mention that an update of the statistics were published a few weeks back. But anyway, the message is that infectiousness started indeed several days before the onset of symptoms. It is rare up to, let's say, 3 days, but you can see that that infectiousness is peaked at indeed symptom onset. In the original papers, it was minus 0.7 days, so even before you have your symptoms. But let's say that at the onset of symptoms, you are most infectious if you're infected with the virus. It could start already before symptom onset. And then the other a very important figure that was not changed with the statistics was that 44% of the infections happen in the pre-symptomatic period. So you have pre-symptomatic transmission in 44% of the proportion of the cases. And that really was a staggering figure that was published in May in this Nature paper. It was a landmark paper. It made us realize why we had such a huge problem in controlling this pandemic, because of a lot of infections that occurred before actually symptoms appeared. So then comes the question, of course, how long do you remain infectious? And when the pandemic started in, let's say, January, February, we were focusing a lot on RNA shedding. And we were looking at indeed of how long can you find RNA? And I think we were maybe looking at the wrong signal, or at least at the wrong data, because we were very impressed by for instance, a study coming from Korea, where they looked at 226 repositive patients. So those are symptomatic patients testing positive after discharge from isolation. What they found was that on average, 44.9 days after symptom onset, you could still have a positive PCR. And that created a lot of concern, because then what people were saying, well, maybe you'll remain infectious for many, many weeks. But however, what these people also showed that was that in fact, when you look at these people, they looked at 108 cases, none of them they were able to culture the virus, and none of them were able to infect other people beyond a certain period. So maybe we were looking at the wrong data at the beginning of the pandemic. We were focused too much on RNA shedding, and RNA shedding can indeed last for up to 3 months. Question is, why do we have RNA for such a long time in these upper respiratory tract samples? Probably because you have some genomic RNA fragments that are associated tightly with intracellular vesicles that protect them from degradation by the host enzymes. So so PCR is not clearly a good indicator of transmissibility, and that was shown in another very nice paper, also published in Nature in May of this year, looking at the hamster model. And I'll cut a very long story short. What they did here was to infect the hamsters at the top of the slide with the virus. They could see, and they looked at the evolution of the hamsters, and basically the marker for infection is the weight of the hamsters. So what they could see was that they could find the virus and could culture the virus from these nasal washings from those hamsters up until about 4 days, although PCR remained positive. But then the interesting thing was at the bottom of the slide, when they then put naive hamsters with these infected hamsters, what they could clearly demonstrate was that infection occurs within 7 days of virus present in the nasal washings. So again, not related to PCR, not a good indicator of transmissibility, but you really need to look at the virus culture. Now, there have been several studies looking at infectivity among symptomatic patients. So if you have a patient with COVID-19, patient develops symptoms, how long is this patient infectious for other people? And that's a very important question, and it's an important question about how long do you keep these people then in quarantine, and how long can they indeed infect other people? And so a few studies, this was one of the first studies done in Germany by the group of Liston Doston, again a Nature paper, where they looked at infectivity among 9 adult symptomatic patients with mild illness. Then the top of the slide, you see all the throat swabs and nasopharyngeal swabs that they analyzed by looking at PCR at RNA. And at the bottom of the slide, you see the results of the culture. And again, you see that PCR remained positive for several days after of post-symptom onset, but when they looked at the cultures, you could see that they could not culture the virus beyond 8 days. So these let's say these symptomatic people, these mild symptomatic people remained infectious, obviously for about a week, and your PCR can be positive for many more weeks afterwards, but that doesn't mean that they are still infectious. And that was an important notion that was published with this first paper in Nature by the German group. Another study came to the same conclusion. It was never published, but these are CDC data, again looking at the infectivity among adult symptomatic patients. Here you see a range of different severities of illness, but again, it was shown very nicely, the left on the slide, that they were not able to culture the virus when PCR beyond after 9 days of post-symptom onset. So again, your PCR can remain positive, but your culture will be negative. Um, Interestingly, and I'll come back to this, they also showed that you were not able to culture virus when the PCR CT values were higher than 35. So these magic CT values is something I'll come back to later, because it's a very important part of the discussion about how to use PCR and how to interpret the CT values. So again, these patients beyond, let's say, 9 days, not infectious any longer. And then so the discussion then was, okay, fine. So in mild symptomatic people or patients, they're not infectious for a very long time. So that's in a way good news. We don't need to keep them in quarantine for, let's say, 2 weeks, although that's still a recommendation by many public health organizations. But what about people who have severe illness? So this was one study published recently looking at 129 patients. Most of them were admitted to the ICU, looking at, again, at lower respiratory samples, and they found that indeed you can, among those patients, they could find a replication competent virus, so viable viruses within 8 days for sure, but they also found that actually they could still find viable viruses even after 20 days. And so the story is a bit different. If you have a severely ill patient, or immunocompromised patient, their viral shedding could be longer and you could be more infectious than in the mild asymptomatic cases. So then comes the question, of course, is the data on recovery of this viable, of the replication competent virus following symptom onset, is this mirrored by data on transmission rate? So if indeed people remain infectious, have replication competent virus, let's say for about a week or so, because that was now shown in several studies, is this mirrored by the fact that they will indeed transmit the virus and that they can infect other people? And this was a fantastic study published in JAMA from a group in Taiwan, where they looked at 100 patients with COVID-19, mostly mild disease, and then looked at nearly 3,000 close contacts. On the left, they followed 22 secondary cases with an infection. What they could show that some were exposed even before symptom onset, as we could expect now, but that exposures happened until 5 days after a contact with these index cases. And then when you look at when you look at the secondary attack rates, and if you look at if you look at the presence of the virus in these samples, they could clearly show that the virus was, or let's say they were only infected if the virus was present in these samples up until 6 to 7 days. And after 5 days, there were no secondary cases. So all the infections occurred within 5 to 6 days. There were no infections after 5 to 6 days. So again, this was a very important information that was missing. Indeed, there are infections for about a week, but do we have evidence that they actually also transmit the virus during these first, let's say, 5 to 6 days? So our conclusion is that in mild or moderate COVID-19 patients, you can find viable or replication competent virus for up to, let's say, about 8 to 10 days and not beyond those. And so we have a very indeed short serial interval of about 4 to 5 days, and that is due to as I said, the combined early stage of transmission before symptoms arise, but also the short period of infections. As I explained to you, they're only infectious for about 5 to 6 days. In severe case, that's a different story, and you can find the virus up to 20 days, but in a way that's less relevant for our discussion today. So that was a very important information from a public health perspective and also from a diagnostic perspective. However, I have to admit that there are no data on children or infants, so that may be perhaps a different story. So this is just a summary. If you have a person who gets, let's say, who is infected who's infected with the COVID-19 virus, the peak viral load and effectivity will be a few days before and a few days after the symptom onset. So let's say 2 to 3 days before you can become infectious, with a peak around the moment where you develop symptoms, and you remain infectious for about, let's say, 4 or 5 days, and the majority of the secondary infections will have occurred by day 5, and the virus will be cultured up to, let's say, day 10, and you will be unable to culture the virus in these mild and moderately ill patients beyond this time point. In severely ill patients, that could be different, could be up to 15 to 20 days. And again, the PCR can remain positive for up to, let's say, 3 months. And so you can have a recurrent positive PCR beyond 3 months beyond patient onset. Nevertheless, with high CT values, they're probably not contagious, and I'll come back to this very important discussion, because the last weeks have been some interesting papers discussing the value of CT of expressing CT values, or at least the need to express the CT values. Now, are the CT values completely useless? Can we actually forget about a PCR, or is there still a role for PCR, particularly for expressing results in CT values? Well, an interesting paper was published this month by a group in Marseille looking at the CT values and correlation of the CT values with the presence of the viable virus. And so this paper basically showed that among 183 PCR positive samples from 155 patients, that again you can find PCR positive up to 20 days after symptom onset. We know that now, that it could persist for several weeks even. Again, they were unable to culture the virus after 8 days. It confirms again that the first week you're infectious, you can culture the virus, but not beyond that. But most importantly, what I found that samples with CT values of 13 to 17, around here, that they could, in 100% of the samples, of nearly 100% of the samples, they could culture the virus. So CT values of 13 to 17 or 18, nearly 100% of the samples, they could culture the virus. And then, let's say, the success of rates of culturing the virus goes down, and beyond the CT value of 34, you could no longer culture the virus. Although in many labs, a CT, let's say of 35, 36, 37, will be still reported as a positive PCR result. And again, that's a very important message, and I will come back to that. So you could say, great, don't forget about, we still continue to do PCR. It's a very important diagnostic test, and I would certainly not discuss that or want to question that. And indeed, let's then use CT values, and let's not just report on positive or negative, but let's also report on the CT values. Now, that's not so simple, and this is just a very nice, neat study published in the Journal of Clinical Virology a few weeks back, looking at the CT values for different commercial diagnostic tests. And they tested not a lot of samples, only 13 positive clinical samples, and then they reported the results according to the instructions of the manufacturer, and the data points above the dotted line are negative. So in this case, the cutoff was a CT value of 42.5. Now, all tests detected samples with high viral load and find all samples with high viral loads and low CT values were culture positive, but there were discordant results around, let's say, the CT value of around between 35 and 40, and you can have discordant results. And in some of the diagnostic tests, these samples were reported as being negative, for instance, in this test, whereas in other tests, all the samples were reported positive, and they were supposed to be positive by culture as well. So that's where there's an issue about the CT values. Labs use different platforms, and you cannot set let's say, a standard for a threshold for the whole country, because again, of different platforms are being used, and that makes it very, of course, very complicated. So I'd like to summarize now the viral dynamics with some key facts now that we all agree upon. So the median duration of viral shedding is about 17 days for upper respiratory tract samples, but it's longer in all the age groups, more severely ill patients, and also immunocompromised patients. However, the maximum duration can be up to, let's say, nearly 3 months. The peak RNA load in the upper respiratory samples, throat samples, nasal swabs, etc., is really about the time of onset until 3 to 5 days. So it's a very short period of infectiousness. Um, Very important information that was also published. I didn't have the time to discuss this in the town called Vaux in Italy. A fantastic trial that they did in Vaux, in a small town, Italy, where they showed for the first time that the viral load is comparable among symptomatic and asymptomatic patients, and that's particularly a very challenging. That's a result of the study that you have high viral load also in people who are asymptomatic but who remain asymptomatic, because you have pre-symptomatics, people who have no symptoms but eventually develop symptoms, and you have people who remain asymptomatic. Well, the viral load seems to be in most studies the same in the asymptomatic and in the symptomatic people. No study has cultured the live virus beyond, let's say, day 9 of illness, despite persistently high viral loads, and that's also surprising. You can still have a low CT value and a high viral load, and nevertheless, beyond 8 to 9 days, the viral cultures will remain negative, and you're not infectious. And no culture was also no virus was cultured from RT-PCR positive specimens beyond with a viral load of less than 10 to the 6th copies per ml. That seems to be the cutoff for culturing a virus at 10 to the 6th copies per ml. So let me move on, and I will be very brief on the duration of the quarantine. Just the 2 slides, and I don't want to dwell on this, but I thought it was interesting for you to know that globally there are lots of discussions now about quarantine and the duration of quarantine. And in Europe, countries are now shortening the duration of quarantine. But you need to make a distinction, and I see some confusion about this and mistakes about this. You need to make a mistake and a distinction between, let's say, the reducing the risk of SARS corona reintroduction and reinfection from international travels versus those who had high risk contacts. And John Edmonds has recently published some very nice data modeling how long you should quarantine people who have been traveling in high risk zones, and whether PCR can reduce the quarantine duration in these travelers. And so this is what they've shown, and just so you refer to this part of the slide. They found that this is a copy paste from the slide. So they found that 8-day quarantine with a test on day 7 can be 94% effective on average. Of course, if you do a 14-day quarantine with no testing, you have 99% effectiveness. But we all know that people will not stay in quarantine for 14 days, or at least most people will not do that. It has a huge economical cost. And so people are realizing now that it doesn't make sense to ask people to stay for 2 weeks in their houses. And so if you look at, if you test on day 7 for travelers, keep them then in quarantine for 8 days, you have 94 effectiveness. And even if you have a 6 days quarantine with a test on day 5, you can still have an 88% effectiveness. So several countries in Europe have now decided to quarantine for about 7 days, some even 10 days still, but many have now moved to 7 days and testing, for instance, on day 7. And what they also showed, that there is no point testing somebody who arrives at an airport. For instance, in my country, you can get tested now when you arrive at the airport. They've shown that there's no point in doing that. It's useless to test people when they arrive at the airport. You should really wait, and tests should not be done indeed when they arrive. Now, the situation for high risk contact is of course very different, and we need to make that distinction. And there they've shown, and I'll particularly refer to this part of the slide, that if you quarantine for 10 days with a test on day 8, you can indeed reduce your median transmission potential by 68%. And so that is good. Question is it good enough? And should you still keep them for 14 days of quarantine when they have been in contact and there is a high risk contact, or can you shorten as well? Lots of discussions in several countries in Europe. I don't know what happens in the rest of the world, but I can tell you that in Europe, several countries have reduced quarantining also for high risk contacts to 7 days. And for instance, in France, recently decided that the quarantine period is now 7 days with testing day 7. In my country, it was decided a couple of weeks back, 7 days quarantine, testing day 5, which I think is too soon. I know that in Germany they're discussing this as well. I know that in other countries they're discussing this as well. So just for you to be aware that this quarantine period of 14 days is now being questioned, it's being reduced, and diagnostics will hopefully change the direction again of this perfect storm and will allow us to shorten the quarantine periods. So let me move on now to the role of children. this has been a debate for months, and it's still not being solved. And there are people who are convinced, and I'll just, a few introductory words before I will continue with just the 3 slides. There are people who are convinced that children play an important role in the spread of the virus, and that children are driving the pandemic. And of course, then you need to discuss, are we talking about, let's say, children from primary school up to 12 years of age? Are we talking about children from secondary school, let's say up to 17 or 18 years of age? Or are we talking about universities? So that's already a big distinction. So several people are saying, well, even in smaller children, you can find high viral loads, and you can expect that these kids are going to infect other kids at school. They're going to infect their teachers. They're going to bring it to their families, in fact, their parents and grandparents, etc. So there are the people who have been very adamant in saying that children play an important role. You should not open the schools. There are other people who are saying, well, where's the evidence that children really play an important role? Can they actually infect adults? Can they infect other children? Where is your evidence, and what can you say about this? And so I just wanted to give you one slide or share with you one slide. This has been my favorite topics, and I've been following this literature from the very beginning. I'm more on the side of the children, to be honest, but I'm happy to come back to this. But this was just a paper published a few weeks back in JAMA Pediatrics, looking at the susceptibility to SARS-CoV-2 infection among contact children and adolescents compared to adults. So it was a great study. It was a systematic review and a meta-analysis that looked at all the data published until the 25th of September, so it's a very recent paper. Looked at 18 contact tracing studies, and what they've shown was that children and adolescents have a lower susceptibility to SARS-CoV-2 than adults in contact tracing studies with a pooled odds ratio of 0.59. So in other words, 59%, the children are 59% less susceptible than, for instance, the adults. Particularly in the children less than 14 years of age, in the contact tracing studies, you don't find a lot of children between, let's say, 14 and 18, so maybe they behave like adults, but certainly under the age of 14, they seem to be less susceptible than adults, and in terms of susceptibility to infection, indeed. Now, what about transmission of children to others, to, let's say, other children and to adults? So I think so far, these data suggest that they are infecting less adults and also children based on these household transmission studies, based on studies in schools. But I have to be honest that these were studies done under strict control measures when there's less testing and when schools were closed. So that's why people have been saying, yeah, well, you could say that children are less susceptible to the virus, that even if they are infected, they don't transmit the virus to, let's say, other children or to adults. But that was all, during this, let's say, in Europe during the spring, when they, during lockdown, closed the schools. It's going to be a disaster when we are going to open the schools, so we shouldn't do that. A lot of, let's say, emotional debates in my country also, and I know also in many other countries. Let me just share with you a report that was published last week. A very interesting report looking at the school status of for 191 countries and students by school status and income level. So this was actually a very interesting report. What it shows was that, and so green is students in open schools. Yellow is schools that partially open. So this is all, from all age group, if you like, and not making a distinction between different types of schools. And then red means that the schools are basically closed. What you can see is that that now, and this is again up to September 20. This study was done up till the 29th of September, so these are very recent data. You can see that in the Western Europe, all countries opened their schools despite the threat of a second wave. But what you can also see is that in low-middle income countries, many schools are still closed or still partially open. And what they have published in this report that 711 million primary and secondary students out of 1.6 billion students will not return to school in 2020, and 84% of them are in low-middle income countries. So a lot of children will not be going to school in 2020, and that is a disaster for many of these children, for many reasons, of course. They also looked at the school status for 45 countries during the second wave. I don't have the time to discuss this in great detail, but it's something certainly you should look at this report if you're interested. And again, looking at 45 countries, you see that for these 45 countries, 62% of schools were open, 27% partially, 4% were closed, and then 2% were actually on schools still on vacation. And so I took only three examples: Japan, Portugal, and France. And so again, red is closed, yellow is partially open, and green is totally open. For instance, Japan, you saw that they already closed the schools before they started their first wave. Then during the first wave, they started reopening schools, and actually the Japanese invested massively in digital learning, also did many other things, but they invested massively in digital learning. And then the schools was reopened while the cases had gone down. Then the schools remained open as the numbers were going up, and then had a vacation, and then they were open again. So that's just one example. I could discuss this also for Portugal and for France, and I chose them because they have a different policy. Again, I don't have the time to discuss them in great detail, but I would really invite you to look at this very interesting report. It's available now on the website. So in other words, I think it was good that in Western Europe we decided to open the schools, and I can tell you in my country, I was also in favor of this. But in my country, people were criticizing me and saying this is unacceptable, this is unethical, because we're going to have a huge increase of the number of cases going to drive the pandemic. We're going to have a second wave, and I don't think the data can show this, but it remains a discussion, let's say a controversial debate. So let me finish now with I think, an interesting topic, the role of saliva. You can see that a lot of countries in the world are struggling with testing. They are struggling with testing because we don't have enough swabs. We don't have enough personnel to take in the swabs. So it's a huge burden for the healthcare system to take nasal swabs, throat swabs, nasopharyngeal swabs, etc. And so testing or collecting saliva would of course be a great alternative for let's say detecting the virus in patients who are either showing symptoms or patients who've had high-risk contacts, for instance, and to see whether they are indeed infected, they have been infected with the virus. And for instance, in Hong Kong, early on, already in January, February this year, they started thinking of using saliva, because already in Hong Kong, my colleagues who were working on the SARS 2003 pandemic realized that if this becomes a pandemic, we will not have enough swabs, we will not have enough masks, we will not have enough personal protection equipment, we will not have enough people to collect the samples. We need to think about saliva and even maybe self-sampling of saliva. And so you see now that several countries, and I think it's taken many, many months, and maybe it's taken too long, but many countries are now considering using saliva. Now, is saliva accepted by the population? This was a study done some time back, looking at acceptability of saliva, and then questioning in the qualitative research people whether they would be willing to take saliva at home, what to think about throat swabs, blood samples, etc. And it's clear from this stuff, from this survey, if you like, that that saliva is regarded as highly acceptable, and probably the most accepted sample, understandably, of course, among all the samples that we know for collection or for diagnosing infection with this virus. So why saliva? And then why early morning saliva? And I'll explain what I mean about this. Well, first of all, we know that you can have an infection of the epithelial cells in the salivary gland ducts. So the virus can be in these salivary gland ducts and can indeed affect epithelial cells. So that's one good reason why saliva could be an interesting, let's say, sample to collect to detect the virus. But there's another reason. Particularly to collect early morning saliva. And you can see here the different, let's say, the parts of the upper respiratory tract. What has been shown is that during the night, secretions from the upper airways will pool here, let's say just above the posterior oropharynx. So here you have your oropharynx. So during the nighttime, during this supine posture of sleep, you will collect saliva at the posterior oropharynx. But also during the night, secretions from the lower airways will also move by ciliary activity, again just above the posterior oropharynx. So probably what is very important is to collect particularly that saliva from the posterior oropharynx. And for that, you need to do certain gesture. It might not sound very nice if I would do this now online, because I would make a sound that you might not like to hear. But that's the way it's been done in Hong Kong, and that's how they show people how you can produce this saliva from the posterior oropharynx. So there are many advantages of using saliva, of collecting saliva. It can be provided by patients without any invasive procedures, obviously. It reduces also, I didn't mention this so far, but it reduces the risk of nosocomial transmission. So transmission, for instance, in hospital, where you collect the samples through a nasal pharyngeal swab, or through oral swabbing, or through nasal swabbing. During this, let's say, collection, you can get transmission. And if you ask people to collect saliva themselves, you will have much less of risk of transmission. You don't need to use swabs. You don't need to use flock swabs. In many countries are already now in Europe struggling with the flock swabs and do not have enough of these for the moment. There's no need for trained medical personnel. You have a lower consumption of protective equipment. It's certainly much cheaper. You can, and that is one of the main reasons why I wanted to discuss this, you can use saliva samples in a repetitive manner because you can use it for massive repetitive screening, particularly in children. We're going to have chaos in let's say, the northern hemisphere with the coming winter months. We're going to have children with SARS coronavirus. We're going to have children with rhinoviruses, with influenza virus, with RSV virus. And how do we know that it's COVID-19 or it's something else? We don't know basic clinical symptoms. It's impossible. So we might need to test these children repeatedly. You can only use saliva for that. You cannot, particularly in small children, collect these nasopharyngeal swabs. And it shortens also the pre-analytical time. Now, this is just a review we did recently. I don't have time to discuss it in great detail, but it just shows all the data that have been published on saliva. And I can tell you that if you look at all this data up until August of this year, you see some conflicting data. You see some papers, like in recent data, for instance, this was New England Journal of Medicine paper showing that saliva is better than nasopharyngeal swabs. And then you saw another paper showing in the European Journal of Clinical Microbiology that actually nasopharyngeal swabs is better than saliva, or at least in this paper as well, it's better than saliva. So there's a very conflicting data showing that saliva and nasopharyngeal swabs, same sensitivity. Some say that's better, some say that it's worse. And so that remains a debate. But the question is also now, do we actually worry about the fact that we miss some of these cases? Because maybe those with low viral load, with low amount of viable replication competent virus will not infect other people. And so even if we miss them, do we really care about these people? And there's a growing consensus that maybe we shouldn't care about them. Maybe we should just focus on those with high viral loads, so with low CT values, and therefore use saliva. So my conclusions and recommendations, I think saliva detects certainly patients with high viral loads and potential super spreaders, and that's another area of debate now. Should we not really focus on the super spreaders? And have we maybe ignored the importance of super spreaders in driving the pandemic? And I know that in Japan, they've invested a lot more in targeting super spreading event to, let's say, to contain the spread of the virus. And if that's the case, then of course saliva would be an interesting, let's say, specimen to collect, because you could then early on detect these high viral loads and potentially these high super spread events. Also, I would recommend to use early morning posterior or pharyngeal saliva, although I have to admit that if you look at the data, only 2 or 3 papers have looked at it, there's no statistically significant difference with collecting saliva during the other times of the day, but you should certainly not collect saliva in the evenings or after a meal for understandable reasons. And then it's important to have deep throat saliva, so gurgled from the deep throat. Now, it's still, I mean, so you could be happy with the data and you could say, fine, let's then use saliva. And some countries are now doing that. In France, they are considering reimbursement of saliva at the end of this month. In the Netherlands, they are considering reimbursing saliva in October. In Germany, they are considering this as well. So several countries now think, well, maybe we should have enough data. I still think there's an urgent need to optimize and evaluate the collection methods for saliva according to age and settings. And in these clinical studies, I think there's still an urgent need to optimize and evaluate the method of collecting transporting and storing saliva? Is this RNA stable in saliva specimens? Do we need to add something to keep it stable? I think there's also an urgent need to optimize RNA assay methods for saliva. And I think particularly there's an urgent need to study children and asymptomatic patients, because most of the studies that I've shown you before, they are in symptomatic patients. And actually, I didn't mention that in the previous slide, but they are always done in studies with very low numbers. So that brings me then to an interesting debate about clinical versus surveillance testing. What is the role of diagnostics now? And should we use different criteria for diagnostic tests in clinical testing? So in other words, in diagnosing patients with symptoms with COVID-19 versus surveillance testing. In other words, detecting the virus in people who don't have symptoms, where you want to make sure that you detect them early on and isolate them. And so I think we've been wrong in a way by using the criteria for assessing the value of diagnostics looking at clinical testing, and we should use different criteria for surveillance testing. Because in clinical testing, you target symptomatic individuals. Diagnosis can be delayed because it doesn't need to have additional infections. You can isolate the patient while he has symptoms, so it's not that important. And so you need certainly high accuracy and high analytical sensitivity, and you don't care really about the cost for clinical testing. Surveillance as testing, so screening people with no symptoms, that's a different story. Here, your delay compromises the effectiveness of the program to prevent spread. You need, therefore, fast pre-analytical and turnaround times. You need maybe less sensitive methods, but they should be non-invasive, inexpensive, and easy to execute. And so this was a paper published last week in the New England Journal of Medicine. It's a very interesting paper, and the same group have done some very nice modeling, and I'll just share one slide with you. But they looked at the infectiousness, and then looking at whether the antigen test, for instance, or a test with lower analytical sensitivity would be positive versus a test with a high analytical sensitivity, such as the PCR. And I would really recommend to you to look at this paper published last week in the New England Journal of Medicine. The point they were making was that, well, if you have a less sensitive test like an antigen test, the test will be positive when the patient is infectious, maybe negative here, but maybe you don't really care. And so your PCR can be positive pre-infectious period, but then maybe the patient is not infectious, so maybe you shouldn't really worry about this. And so the question is, what is more important now? Is it the sensitivity of the test? Is it the frequency of testing? Or is it the delay in responding the results? And this is a very busy slide, and I have to come to an end now. And again, I would recommend you to read this paper published, I think it was a couple of months back, or one month and a half back, from the same group, looking at modeling surveillance, considering test sensitivities, frequency of testing, and sample to answer reporting times. Basically, and so with a number of, let's say, parameters that were used in this model, but basically the message that they were saying was that you can have a 60%, and this is what they showed, you can have a 60% reduction with weekly sampling and suppression of resurgence based on additional modeling if you indeed test weekly with a less sensitive test, because this is a red limit of detection of 10 to the third copies per ml, and that's a dark color is 10 to the 5th copies per ml. And in a way, sensitivity doesn't really matter. If you do weekly testing and you have rapid reporting your results, it doesn't really matter if it's slightly less sensitive. You can still suppress the resurgence of cases and have a 60% reduction, and that seems to suffice. So that's a very important message. So finishing now, what if SARS now becomes a seasonal coronavirus? And what about herd immunity? And what about reinfections? And are we protected now for several years? And what about vaccines? And this is a paper that we published in Nature a couple of weeks back, looking at data for the 4 other seasonal viruses, and showing that in this paper, when you look at we looked at 10 individuals who have been followed for more than 35 years, where we had sera available, and where we could look at seroconversion and with infection to the 4 other seasonal viruses. And what we showed in the paper was that beyond 12 months of infection with one of the 4 other coronaviruses, you could start having reinfections. And so our message in this Nature paper was, well, maybe if this virus behaves like the other coronaviruses, then that's not good news. And that means that you can start having reinfections already after 1 year. So let me finish now with some future perspectives. I think, as I said, COVID-19 was really a victory of science. except in clinical research, where I think we failed to do good global clinical trials. I am particularly frustrated about the fact that we didn't do very good diagnostic trials. You've seen the trials on saliva, very low numbers. Massive amount of money has been invested in the clinical trials with drugs, in therapeutic trials. Many of the trials were too small because every physician, also in my hospital, every physician who saw 5 patients wanted to have his own protocol and wanted to study his own patients. And that led to hundreds of clinical trials with very little, let's say, data that help us now for the second wave, and particularly no good clinical trials, particularly on diagnostics. And I think that's where we failed. And I should say. And so the future of the virus would really depend on three things: our behavior. And I think we need to focus a lot more on solidarity and responsibility. It's not the responsibility of the politicians to keep a distance, but it's really our responsibility. And I think the message should really be, particularly among the young people, that if they protect themselves, they also protect their parents and they protect their grandparents. And that message has not been conveyed enough, certainly not in my country, certainly not in most European countries, and maybe not even globally. I think it will depend on the immunity of the population. And as I'm a bit worried about, the data we've published in Nature a couple of weeks back showing that you could have reinfections already after 1 year with the other coronaviruses. So let's hope that this virus is the rebel of the family and doesn't behave like the other viruses. And then, of course, it depends on the vaccine. And we're all expecting vaccines, several vaccines next year. But is that going to be the holy grail? That remains to be seen. So thank you very much for your attention.